going to DC the glucose infusion so that D5LR, we've already stopped our insulin, probably during the pushing process. And we're going to then continue to assess mom's blood sugars, okay, until we have some normal range for several in a row. So in the postpartum period, her glucose levels will fall and her need for insulin in the first 24 hours will be minimal, okay? So that placenta delivers, and so the placenta, did you know, is an organ? The only organ that you grow and lose. Sorry, men, you will never have a placenta. Only women, okay? Has anybody ever seen the meme that says, I can't have any more children? They removed my placenta with my last delivery. Okay. Cracks me up. Because your placenta grows and goes away with every delivery. Yes, ma'am?
I've heard people say they remove their uterus when they do.
Yes! Some people think that they took my uterus out. Well, they didn't. It probably felt that way every time I came in and rubbed the fundus. You know, because they always grab your hand. But we don't. It's still there. So that placenta delivers. That hormone, that HPL hormone, abruptly stops. So you have a decrease of anti-insulin properties, so your body no longer has those hormones being produced by that placenta, causing that anti-insulin properties. And you're going to have a decrease in glucose levels. So what is our mom potentially at risk for now? Hypoglycemia. Okay, we've got to be vigilant and continue to monitor because she potentially could develop some hypoglycemia or hyperglycemia. Depends on what type, how brittle diabetic they are. So how are we going to manage this postpartum? So the first 24 hours, those insulin requirements decrease. We're going to have little to no insulin need at all. We're going to monitor those blood sugars. A type 1 diabetic may then still need to be on a sliding scale insulin protocol depending on what her sugars are. And if she's breastfeeding, you're going to see a decrease in need for insulin. We want to encourage mom as she is breastfeeding to also have like a pre-nursing snack, okay? Just like we want them to encourage them to have lots and lots and lots of water or fluids while they're breastfeeding, we need to have a diabetic mom make sure they're eating prior to breastfeeding. They have a very high metabolic demand when breastfeeding, okay? Which is going to require a need for extra calories. So caloric intake for breastfeeding on a normal mom is going to increase by 500 to 800 calories above that pre-pregnancy caloric intake, okay? So a diabetic mom may even be a little bit more. So what are you as a nurse going to do? Okay? So on page 274 in your book, so when you get home you can look, it's going to go over these different things. Okay? So for assessment, we're going to continue blood glucose monitoring. We're going to assess for infections. So if we have a mom who's diabetic and had a C-section, is she going to be at greater risk for having an incisional infection? Yes, she is. Okay? I've worked in facilities, if we have moms who are obese, have diabetes, they immediately get a wound vac at delivery via C-section over that incision to help reduce that risk of infection. Because when you're morbidly obese, you have diabetes, you're at a greater risk of infection. And so to reduce that risk, they immediately slap on a wound vac to help pull out any exudate and reduce that risk of bacteria getting to that incision. You're going to have vascular changes. Tell me some things you see in women who are pregnant when it comes to vascular changes that aren't even diabetic. Edema, okay. Because of swell, you got extra swelling. Okay, what else?
Varicose veins. Varicose veins.
Varicose veins, yes. Those horrid things. Do you only get varicose veins in your legs? No. There's a lot of women who develop varicose veins in their labia in pregnancy. Okay? They have a real big risk of developing hematoma post-delivery because of that stretching and that busting of that vascular that vein. Okay? Yeah, I've seen them swell up as they're pushing, and then all of a sudden, it breaks open and pops. Okay? Or the doctor has to lance it, because it's huge. So vascular changes, you're gonna see possibly risk for DVTs post-delivery, right? DVTs in pregnancy is high. The other thing we have to think of is stress management. How are they handling the management of diabetes, the stress of being pregnant, and now the stress of having a newborn? Okay? Think about just being a normal mom who has no other medical conditions rather than just having a baby, but now you add on the risk of having issues with your diabetes on top of that. Okay? So what are some interventions? We're going to teach glucose monitoring. We're going to teach how to give themselves insulin injections and further care from there. How are they going to care for themselves? Teach for signs and symptoms of hyperglycemia and hypoglycemia. So again, on page 274 in your book, it's going to go into great detail on all of these things. Oh yay, my favorite part. Practice question. Okay. So what we're going to do is we're going to look at this question, and I want you guys to tell me what is the most important part of this question, okay? So a nurse implements a teaching plan for a pregnant client who is newly diagnosed with GDM, which is gestational diabetes mellitus. Which statement made by the client indicates a need for further teaching? So tell me some important terms we need to look at in our question.
Further teaching.
Okay, GDM, further teaching. Okay. Okay. Which statement? So we know it's a statement. Okay. Which statement made by the client indicates a need for further teaching? So what are we looking for? Are we looking for a correct statement or a wrong statement?
Wrong.
A wrong statement. Okay? That's important to know, right? When you're looking at your answers, you need to know, am I looking for a correct or a wrong? Okay? So, let's read our answers. I should stay on the diabetic diet. True, that's correct, right? I should perform glucose monitoring at home.
True.
That is true. I should avoid exercise because of the negative effects of insulin production.
False.
False. Okay, let's read the lesson. I should be aware of any infections and report signs of infection immediately to my healthcare provider.
True.
True. Okay. So does this help simplify how to break down a question? Okay. When you're looking at NCLEX style questions, you're going to have lots of words in your question, but some of those can be meaningless. It give you a nurse implements a teaching plan for a pregnant woman with cardiac conditions who is newly diagnosed with diabetes. Is that cardiac condition have anything to do with our question? No. So that's why you have to break down your question and see what's important. Good job. Okay. Next little one. Okay. So next question. A type 1 diabetic is being seen for preconception counseling. The nurse should emphasize that during the first trimester, the woman may experience which of the following. Okay, so let's look at our question. What are the important things we see?
First trimester.
Okay, first trimester, type 1 diabetic. Okay, preconception, so is she pregnant yet? No. So that's an important word. Emphasize. Okay. So we have a type 1 diabetic who's not pregnant yet. She's coming for counseling. Good job for her. She listened to her doctor. What are we as the nurse going to emphasize for her to do at the beginning of her pregnancy? Okay, we broke it down. So these are things that we want her to do. Okay, this is something we want her to do. Okay. So the need for less insulin, she's going to have a need for less insulin than she normally injects. Is that going to be true during the first trimester? Remember, in the first trimester, it does. Their insulin need drops, okay? It goes up later, but it drops at the beginning because of those hormones produced by the placenta. An increased risk for hyperglycemic episodes during the first trimester? Probably not, because remember, her body's building a baby. She's gonna have more caloric use, okay? So her sugars are probably gonna be closer to normal than they ever have been in a long time. She needs to look for signs and symptoms of hydramnios. No. When does a hydramnios occur? Third trimester. You're going to see that later in the pregnancy because that's the amount of fluid around baby, right? And hydramnios is what? Too much? Too little? Just right? Too much. It used to be called polyhydramnios. Now it's just hydramnios. Okay? A need to be hospitalized for fetal teaching.
No.
Is she going to have to be hospitalized? No, she's not going to be hospitalized probably during the first trimester, or maybe later if baby's not doing well and she's not doing well, but not during the first trimester. So, she can, so this one is somewhat true, okay? But our correct answer is 1. She's going to be at a higher risk for hypoglycemic incidences in the first trimester, okay? Now, is that going to be true across the board? No. You are going to sometimes see a mom who does have high blood sugars even in the first trimester. But scientifically, we know the majority of our women are going to have low glycemic or low sugars during that first trimester because of that placenta having those hormones that are helping. So that need for less insulin is normally going to happen in that first trimester, okay? So it's a little bit more difficult question, right? A little bit more content that you had to know about the first trimester. Is that something that should be important to know for your test? Probably.
I think also because maybe like a lot of us would see like would emphasize on type 1 diabetics as opposed
Right.
to like just what happens in the first trimester.
Right, because, right, exactly. As a nurse, you're going to be, oh, she's type 1 diabetic. But when you're when you're a nurse who is dealing with a pregnant patient, you're not only dealing with the type 1 diabetes, but now you're dealing with pregnancy, which is considered a medical condition, okay? So, right, so you as a nurse may be like, oh, type 1 diabetes. But then when it comes to maternity, you kind of have to change your way of thinking a little bit. Because we're not just thinking about mom, we're thinking about that fetus, neonate baby, okay? Okay, let's move on to the next one. So, a client has a history of insulin-dependent diabetes. The client is 10 weeks pregnant and has had persistent nausea and vomiting. The client states her blood glucose has been 60 to 80 milligrams per deciliter. Based on the client's history, what is the nurse priority concern? Okay, so let's look at our key terms. Somebody throw out a key term there. Okay, priority concern. Right, this is big, right? Is that good? No, that's pretty low. 10 weeks pregnant, okay. What else? Okay, so she's had some nausea and vomiting. So is she eating appropriately? Okay. Insulin dependent. That's a big thing, right? So let's start with 4. Glucosuria. Okay, now what is glucosuria? Glucose in the urine, just like it sounds. Okay. Glucogenesis. No. Glucogenesis means the making of sugar, right? Genesis is like the beginning of glucose. And we're going to learn a little bit more about that later. Hyperglycemia? No. So it's hypoglycemia. So our biggest concern is her being hypoglycemic. So what do you think with this 10-week mom, what are we going to do? Tell me some nursing interventions. Okay, snack at bedtime, but she's nauseated and she's vomiting. We're gonna ask our doctor, hey, I think she needs probably an antiemetic, something to help with her nausea, an anti-nausea, okay? So, Zofran is kind of controversial. They say it has an increased risk for what? With pregnancy, does anyone know? There is an increased risk for cleft palate and cardiac issues, okay? But you have to weigh your risk to benefit. So, say she's tried Phenergan, and she's tried B vitamins, and she's done the over-the-counter mom pops, you know, that's got the ginger and everything in it. Is it gonna be more beneficial for her to take that slight risk for potential cardiac cleft palate versus 60 to 80 not being able to eat? Okay, so that's the way you have to look at it with your patient. What's your risk to benefit ratio when it comes to taking a medication, okay? And your physician's gonna go over that with them. But as the nurse, it's very important that you are educated about it, because as soon as that doctor walks out of the room, what are they gonna do? They're gonna ask questions, right? And you're gonna be like, okay? That's why it's very important that you kind of have an idea about these things. Okay, that would be me in a normal clinic, and then someone started asking about their COPD. I'd be like, what's your pulse pulse? 92, okay, that's good, but that's what I wanna. Okay? No, I know a little bit about the respiratory system, but that's how I feel sometimes, because my brain is so full of OB stuff. So, we're gonna try to get her an antiemetic, we're gonna get an anti-nausea, we're gonna encourage what kind of snacks? Crackers, probably carbs, complex and simple, probably something that is bland, right? Because you don't want anything spicy, you don't want anything that's gonna make them feel more nauseated, nothing with strong smells. So think through, what can I give them? Applesauce, the brat diet, bananas, rice, applesauce, toast, okay? That's a good diet to start a mom who's having nausea and vomiting on. Crackers, give them bland things that's not gonna make them all of a sudden feel nauseated when they smell it, okay? Although some people, that bananas does always, so you gotta watch bananas. Okay, one more. Okay. So for 30, I think I didn't copy this correctly. So 4 people, okay, I'm right. 4 38-week gestation gravidas, so 4 patients, hey Ginger, go ahead, laugh at them. 4 patients who are 38 weeks, okay, have just delivered. Which of the babies should be monitored closely by the nurse for respiratory distress? Let's look and see, okay. 4, the babies whose mother has asthma. Do you think they're at a risk for respiratory distress? Probably not as great as some of the others, right? So we're going to think about it. The babies whose mother has hypothyroidism. Okay, probably not. The baby whose mother has lung cancer. Probably not, because is that affecting baby? Or any of the last 3 that we've read affecting babies directly? No. The baby whose mother has diabetes mellitus. Yes, because why? Okay, secretions. Maybe they did not get that development of surfactant due to the diabetes. What else? Possibly, if they go into respiratory distress. What's another reason they would go into respiratory distress besides not having that fetal surfactant? Okay, hypoglycemia, right? All of a sudden, their blood sugar drops. They become lethargic. Do they want to breathe? No. They're not going to want to breathe because they're tired. So then you're going to have a baby that goes into respiratory distress syndrome. Okay? So you have several causes with a diabetic baby of why they could go into respiratory distress. I'm going to make a note to myself. I got to rewrite that question. Okay. So now we're going to talk about anemia in pregnancy. Is pregnancy? Yes. And why is that? We talked about it at the beginning of class. Hemodilution. We have more blood volume and less RBCs for that ratio. So normal RBC ratio if we weren't pregnant, but now because we have more blood volume, we don't have enough RBCs for that blood volume. So we're going to be anemic. So it's not that our body's not producing enough, it's just because of that extra blood volume, we don't have enough. So insufficient hemoglobin production, so we're just producing for our normal everyday body, not a pregnant body. Okay? So a normal hemoglobin for a pregnant person is going to be 11 or greater. Okay? That's low for a normal person, but remember, hemodiluted, so it's going to be normal for a pregnant person. In pregnancy, it's either due to insufficient hemoglobin production or nutritional deficiency of iron or folic acid. Okay? So iron deficiency anemia. Who likes to take iron? Nobody. What does it cause? Constipation. Okay? So, this is where you have a lot of problems with moms who are iron deficient and they have to take iron in pregnancy because what does pregnancy cause? Constipation. And then let's give you this iron pill and make you more constipated, okay? It could be inherited, so maybe you have sickle cell anemia or you have thalassemia, okay? So in your book on page 276, there is a table that kind of breaks down each one of these. It's actually really good to look at and gives you a lot of information. So we're going to look at iron deficiency anemia. Iron deficient anemia is considered the most common complication of pregnancy. This is what you're going to see most often with pregnant women. So during pregnancy, a woman should have an intake of about 1,000 milligrams or more of iron daily. 300 to 400 milligrams goes to the fetus. 500 milligrams is for the increase in maternal RBC mass. 100 milligrams is for the placenta. And 280 milligrams is to replace the 1 milligram of iron lost daily in your feces, urine, and sweat. The greatest need for iron is during the second trimester of pregnancy. So we see hemoglobin start to fail during this time when the iron needs are not being met. So a lot of women being pregnant in an anemic state, and they can turn more severe throughout the pregnancy. So we have a lot of women who already start pregnancy anemic, and then they become more anemic in pregnancy. I've actually had patients who their anemia was so low, had to get iron transfusions or blood transfusions in pregnancy to increase their levels before they deliver. Because what happens when you have a baby? You lose blood a lot in a very short period of time. Okay? So we want to build that up and increase their blood volume prior to delivery. So, what's our goal? It's prevention. Okay? We want to have supplemental iron and an iron-rich diet. Somebody tell me some things that you can eat that are rich in iron. Beans, organ meats, dark leafy greens. Put spinach on everything. Okay? It's hard sometimes for moms just because when you're pregnant, certain things aren't appealing. I don't think I could have eaten organ meat while I was pregnant. I like liver otherwise, but while I'm pregnant, no. But if they can handle red meat's going to be higher than chicken. Okay, so beef. So think about all the iron-rich foods that we need to instruct moms on eating. Okay? So if they're anemic, they should have 60 to 100 milligrams a day of iron supplements. We're going to teach about the iron-rich diet, iron supplements with vitamin C. Why do we need vitamin C? Absorption is going to help your body to absorb that iron. Okay? So orange juice, vitamin C infused orange juice, or just even a vitamin C supplement. We are going to teach them about stool softeners. Okay? In pregnancy, I have told patients to take a stool softener 3 times a day. If their stools are super hard, it's okay. They can even add in a fiber supplement to help with those stools, okay? Just follow your protocol of your provider. Why would they have black caries or black stools? Because of the iron, right? You're gonna teach them about that because people are gonna freak out. Why is my poop black? Okay. Same difference, I would get calls all the time when I worked in the clinic setting. When I pee, it's neon orange or neon green. Why is that? Why would a pregnant woman have neon green pee? Prenatal vitamins, yes. Your prenatal vitamins sometimes is gonna change the color of your urine. And so I'd be like, it's okay, are you taking your prenatal every day? Oh yes. Usually it's my first time moms who are like diligent and we're gonna really good moms. By the third, they're like, I take it sometimes. Okay, I was no nurse every time I was pregnant. I was really bad about taking my prenatal vitamins. I'll admit that. Okay. So what are some implications for our mom and baby if mom is anemic? Hypoxia? Yes, why? You tell me.
Because they're not having the blood carrying oxygen.
Right, our RBCs carry O2, right? So you do have a higher risk of hypoxia. So prenatal, they're going to tire easily. They're not getting enough O2 because their blood can't carry it enough. So what does your body do? Shuts it. Says I'm tired. I can't work. Okay? You're going to be more susceptible to infection. It's going to increase your chances of developing preeclampsia or eclampsia. During that postpartum time, they're at a higher risk for hemorrhage because if their blood count is already low, any amount of bleeding is going to be considered a hemorrhage for them because a hemorrhage, we're not only looking at blood volume, but we're also looking at that H&H post-delivery. Okay? Minimal blood loss isn't going to be tolerated well by this mom. Okay, you're going to have to be careful the first time you get her up. You're going to make sure that you have your little white, smelly good thing in your pocket. What do we use ammonia for? I have taken many showers with moms, not because I chose to, but because they're like, oh, I feel good, I want to take a little quick shower to wash off my body. And they get in there and that hot water hits them. They get all relaxed. They've had a little bit of too much blood loss and they go down. Okay, so we're gonna have our ammonia with us. Make sure we are helping them to the bathroom the first time. They can have delayed wound healing because of their blood volume decrease. What risk do we have to baby? They can have a low birth weight. It could be SGA, small for gestational age. They're at risk for mom's risk for going into preterm labor and having a baby early, so we have preterm delivery. So what are risks for baby if we're preterm?